Welcome back to PeteScript. I'm Zach Hodges.
And I'm Al Shanklin.
And we are both currently ICU fellows, but
hopefully not for long. Today, we're going to be talking about a fabulous topic, honestly, often overlooked, and that is invasive candidiasis.
Yes, and to do that, we have two fantastic guests. First, we have Dr. Paul Su. He's an associate professor of pediatrics at Columbia University and the director of the Pediatric Transplant and Immunocompromised Host Infectious Disease Program at Morgan Stanley Children's Hospital. He completed his pediatric residency in New York, followed by his ID fellowship at Johns Hopkins University in Baltimore. He then moved to UT Southwestern in Dallas, where I had a chance to work with him, but now he's back in New York at Morgan Stanley Children's Hospital. His research interests are all about the impact of invasive fungal and viral infections in immunocompromised hosts, and he is a fantastic guest to have join us today.
Yes. And with him, we have Zach and I's number one open access education icon, Sara Dong. Dr. Sara Dong is an adult and pediatric infectious disease physician at Emory University School of Medicine and at Children's Healthcare of Atlanta, where her clinical focus is also transplant and the immunocompromised host. She did her internal medicine and pediatric residencies at The Ohio State University and Nationwide Children's Hospital, followed by MedPeds ID and even a medical education fellowship at Beth Israel Medical Center and Boston Children's Hospital. Sara's Febrile podcast is not only a fabulous ID podcast, she also makes the best, most consistent infographics we've ever seen, and she has really cool merch.
Yes, so jealous. Would love to borrow some ideas from Sara and the Febrile podcast. We are looking so much to sharing this conversation with you. Let's get right to the episode. Welcome back to the PeteScript podcast. We are so excited to have two guests today, Dr. Sara Dong and Dr. Paul Su. To get things started, will each of you tell us something about yourself and include something that you enjoy outside of medicine?
Hi guys, great to be here. Thanks for having me. So I'm Paul, and I'm a pediatric ID physician here at Columbia. So one thing about me is, I'm originally from New York City. I grew up in Flushing, Queens, not far from the US Open and Citi Field where the Mets play. But I've always been a Yankees fan. And that is something that growing up in the 80s in Queens was not easy to do. So I take a lot of pride in remaining a Yankees fan. And I will say one of the joys of my recent move here has been that I get to drive by Yankee Stadium every morning as I drive up the Harlem River Drive. And so I take a look and I say hi to Babe Ruth and Mariano Rivera.
Oh, well, Paul, as a Long Islander, I find your dedication inspiring. Sara, what about you?
Well, hi, I'm Sara. Thanks for having us on the show. I recently just finished my long training pathway. So I'm a new grad and just started as a new attending. So I'm a transplant ID doc at Emory and Children's Healthcare of Atlanta. So I see adults and kids. I would say for my sort of non-work things, I really like cooking. So perusing and collecting cookbooks or learning about cooking through travel. And I also really enjoy, a good afternoon watching something TV or movie related. Sometimes while crafting or doing Legos or puzzling, that's like the perfect afternoon for me. So
it's great for the snowy winters that we're currently in the middle of, I imagine.
Yeah. All right. So, Paul, can you tell us more about your professional and academic interests as it applies to today's topic?
Absolutely. So as a peds transplant infectious disease doc, I tend to focus clinically on the infections that are the most dangerous to my patients and often, hand in hand, the hardest to treat. The kids that I see, the kids that we see in transplant ID, often live what feels like on the knife's edge. They have to strike the perfect balance every day between immunosuppression and risk of infection, and it's a very narrow space before we, can get into trouble. So when it comes to fungal infections in the immunocompromised population, the mortality and the impacts of fungal infection are very high. We'll talk about it more, I'm sure, but the mortality due to fungal infection ranges from maybe about 15% for some candidal infections to up to 80%. And for many of us in Transplant ID, these are patients that we see, and those numbers are too high. And so we've made a lot of progress in the last few decades, but there's still so many unanswered questions, and there's so much room for improvement. And so for me, when it comes to my academic interests and my clinical interests, they really converge perfectly in transplant infectious diseases. And they converge in the sense that clinically, I want to do whatever I can to get this patient through. Academically, we often don't know what to do. And so the convergence of that really motivates me and makes me love really what we do every day.
Fantastic. And we're excited to explore that more today. Sara, we're also really excited to have you on the show. You're a leader in infectious disease open access education. Please tell me more about what you're doing in that space.
Oh, thanks. I would say that's really my main academic focus is digital medical education. And I'm really passionate about teaching others how to build out those digital education skill sets or that toolbox. So social media, infographics, or other sort of visual communications, podcasting, websites, and so on. I created and host Febrile, which is a little ID podcast that's really based around clinical consult type questions.
And it's very successful, not little.
All the episodes, they have really overly wordy consult notes, just like our inpatient consult notes. And we try to do infographics where we can. In addition to that, we recently had this new initiative called the ID Digital Institute. So I'm the program director for that. So it's a free program and really meant to be a community that helps train folks to navigate digital media as a way to teach. And honestly, to hopefully attract learners to understand how awesome ID is. I know this is a critical care podcast, but we're moving into our second year of that. So I hope that over time we can build out this community in ID because I think it's relatively new compared to critical care and nephrology and cardiology. And think about how do we understand these materials? How do we think about them both for our own portfolios, but like how and why do learners use them and how can we make them better? So lots of fun questions that we can all work on.
That's fantastic. Thank you so much for the hard work that each of you do. Before we jump into the topic today, any conflicts of interest before Alice gives us our case?
Not for me.
None here.
All right. So let's kick it off. We've got a 9-year-old boy with high-risk BALL who is currently in the consolidation phase of his chemotherapy and is admitted to the PICU with concern for septic shock. His course has been complicated by prolonged neutropenia following induction chemotherapy, pancreatitis secondary to PEG asparaginase treatment, and severe mucositis. He has remained febrile with the evidence of ongoing sepsis despite over 72 hours of broad-spectrum antibiotics. You're at the rapid, you've got blood, urine, respiratory cultures that have no growth up until this point. You're going to bring him down to the unit for vitals. So this is a story that we've seen hundreds of times in critical care. Generally speaking, what are the key features of this patient that make you concerned for an invasive fungal infection? And what are the general features that you're looking for in an immunocompromised patient?
Yeah, so I'll say again, this is a very common scenario that we see, and these are really tough cases. Again, when it comes to immunocompromised kids, and when thinking about fungal infections, I think the first thing that I remember, I think the first thing to remember is that fungi, whether it be mold or yeast, is simply ubiquitous, right? And so it's everywhere. The other day, or I left out some bread, right? And a few days, about a week after that, it turned green. And so what was that? That was aspergillus, that was mucor, that was penicillium, Fusarium, right? And these are all things that we don't think about. We simply throw it away. But in our patients, in the susceptible hosts, these are deadly. And so the question that comes to mind in a situation like this is, what do I need to worry about, right? And when do I need to worry? And so there are two components of this. In this patient, the kid is ALL, and really looking at the host and deciding, what is their vulnerability, and whether that be their primary immunodeficiency or their immunodeficiency brought on by their chemotherapy or even the other iatrogenic potential risk factors for them. So in looking at this host, I would say the thing that is most concerning to me is neutropenia. We know that neutrophils are part of the innate immune system and really our first line of defense against fungal infections, especially mold infections, but also yeast infections. And we know that duration of neutropenia is associated with risk for invasive fungal infection, and that anything over 10 days of neutropenia really does increase your risk, and that every day of neutropenia adds a significant risk to you getting an invasive fungal infection. And so I would say, in terms of other factors, that the patient here likely has a line if he was receiving chemotherapy and maybe getting TPN, and also has this history of pancreatitis. So like I said, fungus is everywhere. It's inside of us, as we know, and Candida will often colonize or always colonizes the upper GI tract. And we know that there is an association between things like necrotizing pancreatitis and candidemia. So this kid has a lot going on, and a lot that makes me worried about fungal infection, especially if he's not responding to broad spectrum antibiotics.
And of course, this patient is at risk for infectious candidiasis. Are there any other fungal pathogens that you would be specifically worried about in a patient like this?
Yeah, absolutely. So like I said, in this scenario where he's had prolonged neutropenia, I think in addition to yeast infections, we worry heavily about mold infections. And that kind of brings us to the other part of that breakdown is we need to think about the source or need to think about the potential pathogens. And so this is where infectious disease doctors like to get very excited. And this is where we do our extensive social and travel histories. And so this patient is in consolidation chemotherapy. Well, did they go home between the two induction and consolidation phases? When they went home, did they perchance have an ice storm in their area and have pipes break and develop mold in their kitchen that they had to have repaired? And so they did some excavation, right? These are, somewhat entertaining questions, but these actually, have real implications on our patients. And so whether or not they're from an endemic area, are they from, New Mexico, or have they traveled there? Where are you in the country? All of these things really impact what goes on that list of other infections. And these may be often are invasive molds, the most common being Aspergillus, but we also see, mucormycosis, unfortunately not too infrequently, and other molds, whether the dematiaceous molds or endemic dimorphic fungi, things like histo, blasto, or cocci. But these are often really regional and depend on where you are. But in this patient, depending on those details, they would be at risk for all of them with their prolonged neutropenia. And so these are all part of the equation of looking at host, looking at source, and then trying to come up with the best approach.
So one of my favorite parts of this podcast is I get to display my ignorance. So, just learning about the differences in yeast and mold, and there's other thing called dimorphic fungi. What does a lowly intensivist need to understand about all these different classifications of fungal pathogens?
I would say that actually the breakdown that you gave is probably the most relevant as an ICU doc, is that general thinking of yeast, mold, or dimorphic, or sometimes people say endemic fungi. The reason they're probably the most useful is because that's the first word that's going to pop up on your micro report when you get it, yeast or mold. I think maybe that's a good way to start by looking at it, is that if you see yeast in, for example, a blood culture, there's only so many things that's going to be, and almost always that's probably going to be Candida. There are some other fungi that could grow in a blood culture, like Cryptococcus, but we'll sort of come back to that in the dimorphic fungi. But generally, if you're seeing yeast, in most cases, it's going to be Candida. And then when you think about mold, oftentimes, you have to think a little bit about where the sample's from, but I would say Aspergillus, everyone commonly thinks of initially. And there's lots of pearls there for how Aspergillus looks in tissue path. But it's something to remember is that I wouldn't expect that to grow in a blood culture. So you might have that grow from a tissue culture somewhere. I think one really useful learning pearl is that everyone sort of knows about Aspergillus, but there are a lot of things in tissue that can look the same. So there's another organism called Scedosporium that actually could have very similar clinical features, but would look exactly the same as Aspergillus in tissue. So just keep in mind that sometimes those path review conversations that you have, if it looks like Aspergillus, it potentially is, but there are a couple organisms it could be instead. And then the other sort of big category would be the Mucorales, mucormycosis, which there's several different species names in there, but I think these are the ones that you hear about, those hyaline hyphae with right angle branching, whereas Aspergillus, you hear about acute angle branching. And then I think the other sort of big category for mold would be the one that Paul mentioned, dematiaceous fungi. And then dimorphic fungi means that it can exist as both a mold and the yeast in some temperature in the body. So generally there's, people use the term endemic mycosis, suggesting that this one fungi grows in this one area. I think what we know is that bugs like histoplasma, which is a dimorphic fungi, is almost everywhere now, especially in the US. So I think those terms are useful, but sometimes maybe close people's differential when they should still be considering something like histoplasma. The other one that I would think about when you think about histoplasma is blastomyces, and then Cryptococcus, which can be a yeast that maybe you would see in a blood culture, or it can be a mold. And then, of course, if you practice like out in the Southwest, you can think about coccidioides. These are kind of the big ones that I think would actually come up. And then if you don't recognize the name, I'm assuming you're going to be working with an ID doc that can give more context, but at least that breakdown hopefully is helpful.
Yeah, absolutely. I completely agree with everything that Sara said. I mean, I think that the thing to keep in mind is that in the ICU, by far the most common invasive fungal infection we'll see will be yeast, will be usually Candida. I think the bigger question often is how do you interpret this positive culture? And we may get into that, I'm sure, but it depends on where it's from. Again, it also depends, I think, on the host that you're dealing with, right? And so if you isolate, say, Aspergillus from a non-sterile site and a host who does not have prolonged neutropenia, who has an intact immune system, maybe is on a little bit of T-cell immunosuppression, the host is different. And so I think it's always important to take the culture data and align it with the clinical picture, which really depends to a large degree on what's going on with the host. But I think, as Sara said, I think those categories are the ones that we think about. I think yeast being the most common that we see, molds often being the scary ones that we see because molds are everywhere, but we don't see them very often in the ICU. The frequency of an invasive Aspergillus compared to Candida is probably 10 times less. And so when we see it in the ICU in a patient, it's usually because the host is very immunocompromised and is at high risk. So molds are the ones that I get anxious about. And then the dimorphic fungi, or what have been known as endemic fungi, these we see in immunocompromised patients, but we also see in non-immunocompromised patients. And so classic story is, the older gentleman who went out to Arizona for a week of hiking in the canyon comes in with pneumonia. And that's cocci, right? And we see that in immunocompromised hosts, but we also see that in healthy individuals. There's a story I heard of some of these mud runs, like Tough Mudder, and I don't know if I can say trade names on here, but some of these mud runs.
Yeah.
And I heard this is an anecdotal case, but I heard of a participant, a healthy, Tough Mudder type person doing one of these adventure races and subsequently presented to the hospital. This is somewhere in the southeast and had pulmonary histoplasmosis, right? So these dimorphic or endemic fungi, they don't only target our immunocompromised patients, but definitely something to keep in mind, especially if there are environmental exposures.
I think the other thing, just for like talking to families, is I think sometimes we use a lot of these terms and they do mean something to us, but to families, I think they can mash all together and be confusing. And even though they've been counseled on the risk of a fungal infection, they hear the new name of this bug that doesn't sound familiar and feel like they weren't sort of prepared for it. And I think sort of stepping back and putting that in context for families that ultimately these are organisms, like Paul said, that are just ubiquitous everywhere. And we do have this very specific fancy name for this bug, but ultimately, like the way we approach it, we're treating with the antifungals as best we can. A lot of that is similar. I just have found in talking to families that sometimes that can feel extra overwhelming if it's a new bug name they've never heard of. So trying to put it in context that all of these are things we coexist with. It's just unfortunately your child's immune system wasn't really able to fight against it, and as well as someone else, with the exception, of course, of like histoplasma and some of the other ones that affect our also immunocompetent patients.
Yes. I would say we definitely appreciate having infectious disease consultants to help counsel our families through some of these subtleties of these diagnoses. I have a follow-up question, thinking about practically how we deliver care to these kids. When I think about how, as the healthcare system, our mental model towards taking care of patients with sepsis, it's almost like we are so very focused on treating bacterial sources of sepsis, like early antibiotics. It's a keystone feature of our treatment model. Are there any stopgaps that we should put in our mind that should pique our intention that maybe this is not just run-of-the-mill, strep pneumo sepsis or MRSA sepsis? Is there any kind of particular steps that we should take? If we see this X, Y, or Z factor, we should seriously consider an invasive fungal species.
Yeah, Zach, absolutely. I mean, I think, again, I'm going to keep going back down to this breakdown model that I use because it really dictates most of my thinking on these things. But you need to think about your host, right? And so all of the patients that we're talking about that are at risk for IFI or invasive fungal infection are, of course, at risk for serious bacterial sepsis. But there are unique factors to them often that will increase your suspicion for a fungal infection. For example, we talked about neutropenia. But, even taking away neutropenia, looking at our solid organ transplant kids, these are patients that have had, invasive surgeries. Often in our abdominal transplant surgeries, they've had the liver removed, right? They've had significant disturbance in their GI tracts. These patients are often the sicker patients in the ICU in the sense that they come in with central lines. They come in TPN dependent. They come in malnourished sometimes. They come in on CVVH or on dialysis. And so these are all risk factors for fungal infection. So when you go through the checkbox, should I be worried about fungal infection in this patient? Well, they're neutropenic. They have pancreatitis. So they have upper GI disturbance. They likely have a central lines. They have plastic hanging around in their bodies, and they may be on TPN as well. And so when all those boxes get checked in the host, it doesn't mean they necessarily have a fungal infection, but then your threshold for worrying about it drops significantly. And so for most bacterial infections, I feel like we have an approach. Bacteria typically grows well in culture. If we can get to where the bacteria is, we can isolate it, we can find out what it is, and we can treat it most of the time. When bacteria don't respond to antibiotics, then it's either a source problem or a drug problem or a pathogen problem. And usually when there's a source problem, they may have an empyema, they may have an abdominal collection that just needs to be drained, right? They may have endocarditis, there's a source that we can't get rid of. It may be a drug problem. And so we're seeing increases in multidrug resistant organisms in pediatrics, unfortunately. It's not just our adults, and we can't hide our heads under a rock anymore because it's here. And so when bacterial infections don't respond to therapy and we're waiting for susceptibilities, it may be an issue of drug, and we may need to escalate. We may need to use stronger drugs. But if both of those scenarios are not what's going on, then the question is, if someone is not responding to antibiotics, it's probably a pathogen or process problem. The question becomes, is it a bacterial pathogen or is it not? And in those scenarios, that's when it's important to kind of open your toolbox and start thinking about invasive fungal infections, maybe viral infections, or maybe inflammatory processes that mimic all of these. And so I would say if you have the right host, you have the right setup, and you have a clinical process that doesn't fit, that doesn't make sense, depending on how low your threshold is with that host, then that's usually the trigger for me to start thinking about these things.
Oh, nice. Now, I'm calling you guys up. I got this 9-year-old. I just brought them down to the unit. Maybe we're starting a little bit of epi. They've definitely blown through that 72 hours of broad spectrum therapy. What general principles are you thinking about when you're adding empiric antifungal coverage? What are you going to ask me to add?
Yeah, so if we're concerned about fungal infection, so if they've checked off all those boxes and I'm worried about fungal infection, there's going to be 2 things that I ask you to do. I'm going to ask you, number 1, to look for it, to help me find what we're looking at. And then I'll get to the antifungal question eventually. But really, those 2 things have to go hand in hand. But when we have no data, when we have a high suspicion because the host is the right host, and we're waiting on labs to come back and the bacterial studies have been negative, then the question becomes one of efficacy versus toxicity, right? Because unfortunately with antifungals, these are real issues that we need to address. We can't just ignore. The primary 3 classes of antifungals that you have to choose from, it's like, you have your toolbox here. You have polyenes, which are amphotericin or amphotericin B. You have your echinocandins, which may be anidulafungin or caspofungin or micafungin. And then you have your azoles. And within your azoles, you have multiple generations of azoles, going from fluconazole to itraconazole to voriconazole to posaconazole to isovuconazole and more. And now we have new classes of antifungals that are starting to come out, including ibrexafungerp, which again attack the fungal cell wall of these organisms. I would say, and would love to hear what Sara would say as well, but in general, when we think of the broadest antifungal that we have, not necessarily the best for all pathogens, but if we're worried about fungus and we don't know if it's Candida, We don't know if it's a mold, or we don't know what type of mold. We don't know if it's a dimorphic fungus because this person decided to go camping right before they became neutropenic. Then oftentimes our go-to is amphotericin B liposomal specifically. This will provide really robust coverage against the vast majority of candidal species, as well as solid coverage for your molds, including mucormycosis, aspergillus, and uridomediaceous molds as well. It's also often first line for our endemic dimorphic fungi. And so if we're really unsure and our patient is sick and we feel the need to treat, that's often our go-to. That said, nothing comes cheap, right? There are very high costs that we pay when we start AmBisome. We know that AmBisome, even the liposomal formulation of it, does put a strain on the kidneys. And like I said, as these patients are often already sick, that extra strain on the kidney may be just what they need to tip over into renal failure or AKI. We know that amphotericin or AmBisome often requires significant fluid along with the administration of it. And so again, if this patient is sick and they're intubated and they're on the respirator, that extra amount of fluid may be what tips them over that knife's edge. And then we know that amphotericin and AmBisome also causes electrolyte dysfunction, right? And so if this is a patient that's in the ICU with renal failure, respiratory failure, febrile neutropenia, necrotizing pancreatitis, they have a lot of factors. And so AmBisome is kind of our comfort drug maybe in this setting, but really needs to be weighed against the toxicities that we're going to give to our patient.
So you're thinking amphotericin B because if it's a yeast, not all the candidas are sensitive to fluconazole. Fluconazole is maybe going to be a little slow, so you're going to knock out all of the candidas. If it's an invasive mold, you got the aspergillus mucor in the back of your mind. First line for that as well, and it even works for the dimorphic fungi.
Yes, although nothing is perfect. There are some candidal species rare, but candidal species that may be resistant to AmBisome. Primarily Candida lusitania is the one that we frequently talk about. And also we know that AmBisome is not first line when it comes to invasive aspergillosis. We know that mortality data from studies done over a decade ago now show that voriconazole in terms of mortality is far superior by about 30% in terms of survival over AmBisome. That said, we know that AmBisome does provide some activity against aspergillus. And so until we know, often it is the first step that we will take.
Yeah, I totally agree that AmBisome is what I reach for in like a very immunocompromised patient that you don't know what's going on. They're very sick because your goal is to treat them broadly, quickly. But, I'd say the other patients that probably are in the ICU sometimes, or maybe they have a line and they're there for other reasons and you have a yeast that pops up in a blood culture. In that setting, I'd say most people would reach for, mica or an echinocandin, whichever echinocandin you have on formulary. The caveats for echinocandin, they're very well tolerated. They're a great drug. People really don't tend to run into issues with it. The places where you sometimes worry is that it doesn't really have penetration for, or good penetration for eye, CNS, and urine. So it's not like, let's say someone had like a fungal ball. That's probably not going to be your drug of choice. And then, I think outside of the ICU, maybe there are some settings and certain centers that they may try fluconazole as a first step before mica, but oftentimes the patients who are at risk for candidemia are the patients that would sort of warrant starting with an echinocandin, or they're a little bit sick. But I'd say generally I would avoid using fluke sort of upfront if someone's critically ill, and or if they've had fluke-resistant isolates in the past, or if they're on fluke prophylaxis, like that's probably not the best drug for them. And then you sort of just adjust once you get those susceptibilities back.
So lots of great teaching points here. Maybe I'll read these back to you. So the patient who is most critically ill, you want to reach for broad spectrum agents like amphotericin B. If they are critically ill, but maybe you have some time, you maybe want to lean towards, and plus, weighing the risk and benefits, the echinocandins like micafungin might make a lot of sense, especially if you're not worried about CNS involvement. And then the azoles, maybe for candidiasis at least, maybe aren't the best choice for our critically ill patients, but may serve a good role on maybe the step-down unit. Is that fair to say?
Exactly. Or your step-down agent down the road once they've cleared their cultures.
Yeah, and the azoles, I think the other point just being that for targeted therapy, for things like aspergillus, these are the agents that we'll often go to. But again, the key component to what should I start has also to do with what studies do I need to send.
Yes.
So.
Nice. While we're talking about azoles, I do have one targeted question. So you guys do Transplant ID. I've got a patient with a liver, kidney, heart, some type of transplant, and maybe they even just have something mild, and I just want to give them some fluconazole. Should I do that?
Sounds like a trick question to me.
That's a very vague question. As ID docs, we would like more information.
To rephrase, I've got a patient who's 14 days out from a kidney transplant, and, we're managing it with she's on tacro immunosuppression, and I think that she might just have some vaginal candidiasis. Should I just give her some fluconazole, stop thinking about it? Or should I be a little bit more careful in these solid organ transplant patients?
Yeah, absolutely. I mean, I think that in these solid organ transplants, we do worry, right? We do worry about fungal infections. And we know that mortality from candidiasis in solid organs is not insignificant. So the question, can I just start an anti-yeast fluconazole, is not an infrequent one. That said, we know that, again, there's a cost, right? So many of our solid organ transplant patients are on tacrolimus. And we know that fluconazole or any azole will impact the levels of the tacrolimus, and that those drugs need to be modified accordingly. I think the other question, if the patient has proven candidal vulvovaginitis, I think it's appropriate to treat with caveats and caution. But I think that the other scenario where you're not sure if they have an infection, they don't look like they do, but you're kind of worried that they do. I think that those are the tough scenarios. And, there are some guidelines that do come with that. If you have a high rate of candidemia in your ICU, greater than 5%, then these patients may warrant prophylaxis or fluconazole. If the patient is not just a kidney, but say a kidney liver and had some anastomotic leakage and has some, abdominal contents that may be leaking through the bile, that puts the patient also kind of on a higher risk level. If they've gotten tons of antibiotics before, all of these things will work on the host side. And so if these things all line up and the patient is at high risk, then there may be a role for prophylaxis. But usually prophylaxis differs from, I'm not sure what's going on, and I just like to give fluconazole.
Yeah. And I think a common question we get is, I know you said ampho, but we really don't want to give it. Can we just start POSA? Can we start isavuconazole? Because we've had other patients who are also on it and had similar issues. And I think the big thing, like Paul is emphasizing, is that we need to look for wherever the infection is and define it. And if we're really worried about that patient, we want them on active therapy fast. And so things like POSA, it's going to take a couple of days before it's sort of therapeutic in their system. So I would say that in a patient who's not critically ill, who has some pulmonary nodules and you're trying to figure it out, that's a different setting than someone who is hypotensive and appears like they are in septic shock in the ICU. And that's why we really push for ambisome in those settings, acknowledging that they're a risk, but with the goal of trying to get the patient on targeted therapy, hopefully for whatever it is that we find after the fact.
Yes, all great points. Would love to unpack what the fungal workup might look like for one of our patients, like our case here, prolonged neutropenia, culture negative sepsis. What are those common recommendations that you're making at the bedside? What are the information that you need to help treat this patient best?
Yeah, so I think in addition to cultures, right? So we've talked about blood cultures, whether or not they need urine cultures. There are guidelines put out both by the IDSA for febrile neutropenia, as well as COG, the Children's Oncology Group, on the workup. And so the workup typically would involve a combination of imaging plus or minus biomarker data. And so alluding to what we talked about earlier, what should we start in this patient? The big corollary to that is, what are we looking for, right? So as Sara alluded to, if this is a patient who's not neutropenic, who just has a lot of central lines and has other things going on, that's a really important part of the question. In that patient, you may consider any kind of Candin versus ambisome. But if you're worried about febrile neutropenia and you're worried about invasive fungal infection, I like to think of fungus, particularly mold infections, as coming through just two highways. One is the respiratory tract. So here they're breathing it in, like we talked about earlier. Mold is everywhere. And so it's either going to get stuck in their nose, or maybe they were colonized with it already, Or it's going to go beyond that, right? It's going to go beyond that and get into their lungs, and from their lungs potentially disseminate. Or it's going to come from their gut, right? And in a neutropenic patient, especially if they have some gut dysfunction or some compromise of the gut barrier, we're going to see, risks for infection there. So long answer to your short question. So the fungal workup would consist of a few different things. It would consist of imaging, and this is often a CT of the chest because fungal pneumonia is one of the more common presentations of invasive mold infections. We also want to make sure that we're not missing disseminated lesions, especially in a patient that's neutropenic. When we have focal lesions, these may or may not grow on culture. And these lesions could be candida, they could be Fusarium, they could be Scedosporidium. And so some type of abdominal imaging is often recommended as well. And whether or not that needs to be a CT scan or an ultrasound, I think there's more evidence now that suggests that you don't need to necessarily expose your patient to radiation and that an ultrasound is actually sufficient. And then the role of biomarkers, I think, is somewhat challenging. The reason we talk about biomarkers is because there's data that even though we know candida in the blood grows very, very well, and that our standard blood cultures will detect like one colony forming unit of candida, that about 50% of invasive candidal infections are not in the blood, right? And so some early, few decades ago now, autopsy studies looked and found that about 50% of candida found at autopsy was not found on culture. So this raises the question as to what else can we do? So we know that for certain fungal infections, particularly Aspergillus, the galactomannan assay has been used and has shown reasonable sensitivity, definitely better than nothing, and reasonable specificity as well. I think the discussion around biomarkers, to a large extent, also depends on where you're starting. If your pretest probability for fungal infection is very low, even if the tests are sensitive or specific, your post-test probability is not going to be great. So right now, the recommendations from COG are really not to send, for example, beta-D-glucan as part of your empiric workup. And the reason for that is multiple studies in children have really found a really low incidence of candidemia. And when looking at kids with febrile neutropenia, so beta-D-glucan, while in those studies has demonstrated a very high negative predictive value, the fact of the matter is often it's because there were so few positives in those studies. So the initial workup, I think, is looking for a source. If you do that initial workup and you find, say, a source, you find a pulmonary nodule or you find, a splenic nodule, then the role of these biomarkers may change and they may become more important. Every center, to some degree, will have a slightly different take on the fungal workup. In certain centers, where I was back in Dallas, we had a pretty high rate of invasive mold infections. And it was not infrequent that we would see invasive fungal sinusitis. And so while this is not recommended as part of guidelines, in patients with prolonged fever, febrile neutropenia, a nasal endoscopy was something that we found extremely helpful to decrease mortality and morbidity from invasive fungal sinusitis. That is something that most centers would not do. And oftentimes the recommendation is simply to image if there are symptoms.
Nice. So you're looking at your patient's symptoms. How sick are they? Where are the symptoms? You're getting your imaging of potential sources. Depending on what you find, you've got your pretest probability. And then from there, two common serum assays would be the galactomannan to look for Aspergillus and the beta-D-glucan, which can give us information about Candida, Aspergillus, and other things. Is that safe to say?
Yep.
Okay.
Yeah, that's correct. I mean, I think with beta-D-glucan, again, there are pros and cons to every test. And beta-D-glucan, there are many scenarios in which it can be very difficult to interpret because of cross-reactivity. Essentially, it's detecting beta-D-glucan, which is a component of the cell wall. And there are filters that we use in the ICU. There's gauze that we use in surgery. All of these things which have beta-D-glucan. There's plasma-based products that often will use, cellulose-based filters like IVIG or FFP, which will also have beta-D-glucan. And so again, really important to have a good sense of where your pre-test probability is and to ask, how is this test going to help me interpret what's going on with the patient?
Oh, yeah. Most importantly, as an intensivist, I'm probably going to talk to my transplant ID team before I go digging like this. Yeah.
Can I make one that ID doc and me can't not say it, but the fungal blood cultures are, at different places, they're sometimes called isolator cultures, AFB culture. Basically, they're all kind of talking about the same thing, which is a culture of blood that has a prolonged incubation period. And if there is only one thing that a listener takes away from this, especially in the ICU setting, I would love it to be the point that you should almost never, ever be ordering fungal or mycobacterial or isolator cultures, meaning they have a very specific purpose to try and recover, for example, dimorphic fungi, like maybe if you thought someone had disseminated histoplasmosis, molds or mycobacteria. They are not for Candida, which is what most people are often looking for in a acute setting, because Candida grows in standard blood cultures, which we talked about. So I just want to really reinforce that there are very, very rare occasions where you should be ordering it. And if you do, it's probably in the setting where you're working with your ID team, or at least I would hope that you would. So before you place the order, just run through the thought process of what am I looking for with this test, like any other test, because I think this is a type of test that gets sent and more frequently than it needs to be. And it ties up a lot of your microlabs resources because the techs have to spend more time and follow those, even more so than a routine blood culture. And so you really should only be sending it if you have something specific in mind. So I know a lot of places, their antibiotic or sort of diagnostic stewardship teams have targeted education about what is a fungal blood culture? Why don't we really feel like everyone needs one? And so hopefully if you have questions, I think any ID team member would be happy to talk about it. But I think there's this impression that it's going to capture more, but it's all about what are you looking for? What do you think your patient's clinical syndrome fits with? And we obviously are going to send that test sometimes. It's just pretty infrequent.
Sara, that's so helpful.
And just to add to what Sara was sharing, when you send a test, right, this is something that one of my mentors would always tell me, when you send a test, you need to have a plan for what's going to happen if it's positive, right? And so we know that with fungal isolator blood cultures, these are held for a longer period of time. And that, many of the pathogens that may be detected, maybe you detect, a Candida 28 days out. These raise questions as to false positives. And these raise the issue of what to do with false positive tests. It's like, sorry, I don't know whether I should share this phrase, this little thing or not, but I'm just going to say it. So someone once told me that if you pick your nose in public, you need to have a plan as to what to do if you find something, right? And so same thing goes with fungal blood cultures. There's a significant risk of contamination. There have been multiple studies looking at the utility of fungal blood cultures. I know one of my colleagues in Dallas looked, along with folks in Canada, I think they looked at 10,000 fungal blood cultures and found that there were more contaminants than there were clinically significant results. And we know, as Sara said, Candida grows really well. And we know that dimorphic fungi can also grow in regular blood cultures. And so, again, if you're going to order the test, know what you're going to do if it's positive.
We love leaving a long list for people to send, but we have been really thoughtful about which of those tests, what we would do when any of those come back positive or negative. And so hopefully we can just share that with others that are, sometimes these tests are ordered before we meet the patient. So sometimes it's hard to help people interpret them if we weren't a part of the conversation when they were sent.
During residency, there is a dogma that it sounds like should be challenged of triple cultures, aerobic, anaerobic, fungal. We do the clicks, they're ordered, we're always sending it. And so that does sound like a big area of cleaning up some work for the microlab.
Maybe one quick follow-up question before we update our case. Is procalcitonin helpful for you guys at all when working with a patient for fungal infections? I just imagine the classic teaching being your procalcitonin elevated when bacterial infections, maybe not as elevated with fungal infections. Is it helpful, or is it just another signal out there?
So I'll tell you my take on procalcitonin. I think that the utility of procalcitonin really has yet to be defined, right? I think that we know that it's elevated in bacterial infections at LPS, especially can be associated with higher procalcitonin levels. And so Again, these are biomarkers when we don't have other data to use. That said, in the setting of fungal infection, there may be some utility in being able to ascertain the degree of inflammation, whether it's a procalcitonin or a CRP. There isn't really compelling data to use it to guide therapy in fungal infection.
Yeah, I feel the same way. I don't know that I hinge any decision making on the value. Like I interpreted and added on to all the other labs that they've had, but I don't know that I would use it to say, oh, I'm going to pull off X, Y, and Z antimicrobial from that patient.
Sure.
While we're talking about diagnostic, well, I'm going to throw a few things out there that I think, again, are relevant to this case before we know what's going on. So metagenomic next-generation sequencing is a newer technology that has really started to proliferate. The idea behind what we call MNGS is that it is non-biased, cell-free DNA sequencing. And the technology is quite incredible. You get an aliquot of blood and you send it to this lab, and they will sequence every nucleotide that they can in there. And they'll take those nucleotides and they'll compare them against a bank, which will subtract all the human nucleotides and tell you what additional DNA fragments, these are not even complete sequences, what fragments your sample possesses. This is something that, has been around for, I would say, almost 10 years now. And the question often will come up as to, well, if we don't know what's going on and there's no culture data, should we just send this? Because it will tell you if you have leptospirosis in your blood, and no one should have leptospirosis in their blood. It will tell you if you have rhizopus in your blood, and no one should really have rhizopus in their blood. And so these things can be useful, and they are proliferating. The few caveats I think that are important to keep in mind when thinking about MNGS are, number one, that it is an expensive test, and that it's not covered by most insurances. And so we have an arsenal of standard diagnostics, whether they be culture or PCR or biomarkers, that we can use for our patients to make clinical decisions. And these will not tax the patient more than what they're going to be taxed for. MNGS at this point is not covered by most insurances. So that's one thing. But even beyond that, I think the bigger question is, does MNGS add anything on top of what we already have? And I think the answer is that it depends on your patient. And there are definitely use case scenarios where something like MNGS is useful. There have been quite a few studies looking at things like complicated pneumonia. When your cultures are negative or your PCR is negative, there's a nice study a few years old now out of Rady's Children's, where they looked in the ICU at their patients, I think it was like 15 or 20 patients that had complicated pneumonia, and found that the MNGS assay was able to detect pathogens in almost all of them and led to antibiotic changes in like 40% of them. So primarily what it did was everyone was on Clinda because they didn't have a positive culture, and they found that it was all strep pneumo. So they got de-escalated, yeah. And I think there are other studies that suggest that in specific cases when we can't get good culture data, MNGS may have a role. That said, MNGS for fever, MNGS because the patient doesn't feel great, MNGS for the patient is hypotensive and I don't know why, MNGS for procalcitonin went up today. So all of these scenarios are scenarios in which the yield of MNGS is likely to be low, and it brings us to the same question: what will you do if it's positive? There's a recent study in the last couple of years in CID looking at this. It was a multi-center study that looked at about 80 isolates. And the question was whether MNGS led to changes in therapy. And I would say there have been a number of centers that have also looked at this. And in general, the impact that MNGS generally has is somewhere along the lines of 10%. Sometimes less, sometimes a little more when it's just, looking at all comers. I just say this because I think MNGS is a technology that's heavily marketed, that's more and more popular. And I think the big question is how we use this technology. And the last thing I'll say is, so let's say that we see a large peripheral nodule with a halo sign or a reverse halo sign. So the yield of a BAL there is going to be less than 50%. And so especially if the patient is on antifungals. That said, we may be able to send biomarkers from the BAL, but if you can get a biopsy of that sample, your yield is going to be upwards of 80%, even if they've already been on antifungals. There have been a number of studies also that have looked at this, and I think people are often anxious because these are very sick patients to go in and they're neutropenic to get these biopsies. But I will tell you that these biopsies, once you get culture and susceptibility data, will dictate and will change the course of your treatment for this patient. So just a plug for culture first.
We love cultures.
That's right.
Oh, absolutely.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.